Assalamu alaikum. My name is Omar Ahmad. I'm a fifth-year medical student, and today I'll be giving you a session on pharmacology questions, focusing on the post-midterm material. Okay, we'll see which lectures they are right now. So I have a few different types of questions. So one question you'll see the questions that are long clinical scenarios, other questions that are short, quick facts. So that's usually how it is. Okay. And now because this is a recording, it's not live. So when you see a question, just make sure you pause and then answer it yourself, and then I'll give you the answer. Okay. So let's dive right into it. So the first thing we're going to talk about is anti-epileptics. For anti-epileptics, we want to know a few things, okay, that work for the whole lecture. So we want to know the mechanisms of action of the different drugs. Number two, we want to know their side effects, okay, the specific side effects. It's very important to know the mechanism of action and the side effects of each drug. And that's what we're going to be tested on right now, okay? So let's start off with the first question. So which of the following, so you can pause now. Okay, which of the following is a method of action of valproate? So valproate is one of the anti-epileptics, okay? Now, you want to remember in general that what do anti-epileptics want to do? They want to decrease the action potential that's occurring in the neurons, okay? Because the more action potentials you have, that's like the pathophysiology of seizures, okay? A lot of action potential. So how can you decrease action potential? By making it more negative. Okay, if you want to make it more negative, what can you do? You can inhibit calcium going in because that's positive, and you can inhibit sodium going in because that's also positive, or you can make chloride go in because that's negative. So that's how you want to decrease the positivity, okay? So for valproate specifically, the answer would be C here. Why? Because that is the method of action. You want to inhibit GABA transaminase, which causes an increase in GABA. And valproate also inhibits sodium and T-type calcium channels. So it has three different mechanisms of actions. The main ones are these two that I mentioned here in C. Inhibits GABA transaminase and sodium channels. What is GABA transaminase? It is the enzyme that breaks down GABA. So if you inhibit the enzyme, you're going to have more of GABA. GABA is inhibitory. It leads to chloride influx. So that's why you want to do that, okay? Now, what's B? Leads to chloride influx. Why is that not right here specifically? Because this is more towards benzodiazepines and barbiturates. If you remember, benzodiazepines increase the frequency of chloride channels opening, and barbiturates increase the duration, okay? And then inhibits T-type calcium channels only. That is ethosuximide, okay? So these are the specific, this is a very important table you want to remember. Phenytoin and carbamazepine, they work by blocking sodium channels. Valproic acid, as I said, sodium channels and GABA levels. And then benzodiazepine and phenobarbital, like I just explained, and ethosuximide, T-type calcium channels. And you'll see when ethosuximide is going to be used soon, okay? This is the next question. You can pause. Okay, now the answer. So what is the patient here? The patient says that he had absence seizures. He was given a medication and now he's better. You need to know what that medication is. They don't tell it to you. So what are absence seizures? First of all, it usually occurs in children less than the age of 10. It's when they get multiple episodes of just staring off, like for 5 to 10 seconds. They're just unaware of their surroundings. It's a generalized seizure. It's not focal, okay? And the treatment for it is ethosuximide. It's very important you remember this. It's ethosuximide, okay? So ethosuximide, what is the method of action of ethosuximide? I hope you said the answer is C. Decreases the calcium current in thalamic neurons, like I showed you here. Blocks thalamic type T, type C channels, type T-type channels, okay? That's very important to remember. These are how the questions can be formulated, okay? Let's move on. So this is exactly what I explained. Third question. A pregnant patient comes with seizures. So the new thing here is that the patient is pregnant. Okay, she has seizures, but she's pregnant. So in pregnancy, you remember that some medications can be teratogenic. They can affect the fetus. So anti-epileptics are famous for affecting the fetus by causing fetal neural tube defects. Okay, fetal neural tube defects. It's extremely important. All of this information is going to be sticking with you till you're in 5th year internship. This is going to come over and over again. Okay, remember this. Like I just did my neuro rotation in 5th year, and we still have these questions. Okay, remember that. So the safest drug of these is lamotrigine. The other drugs, they're all teratogenic and they can cause fetal neural tube defects. But if you have to give them, you want to make sure that you give them high dose folic acid as well. Remember, high dose folic acid to be given with these medications, okay? So like I said, they all cause neural tube defects. Phenytoin can also cause something called fetal Hadine-Toin syndrome. It is a syndrome of several different characteristics, okay? So the least teratogenic, lamotrigine, D. Okay, here's the answer. Yeah. Now, degenerative diseases. Okay, I want to move on. So epilepsy. I hope I'm not too fast. If I'm too fast, make sure you look at the 0.75. Epilepsy. What did we say was the important thing? You want to know methods of actions of the different drugs. You want to know if they're indicated in different diseases. Okay. And number three, you want to know that their side effects. Very important. Okay. Also, phenytoin. Remember how it can cause gum hypertrophy. Okay, the gums are going to be swollen. You'll see a picture of that specific, very likely. Okay, if that's a question. Now, degenerative diseases. You have two types, which are Alzheimer and Parkinson. Okay, let's start with Alzheimer. Okay, so Alzheimer's, someone was given a medication and he has sleep disturbances. Now, Alzheimer, what is the medications that are most commonly given? Donepezil, Dongalariva. That's the, it's not a mnemonic, I guess, but it's just a saying. Dongalariva, okay? Donepezin, galantamine, and then rivastigmine, okay? These three drugs are the ones that are given. What are their methods of action? Acetylcholinesterase inhibitors. What does that mean? It means, you know what acetylcholinesterase is? It is the enzyme that breaks down acetylcholine. So you want to inhibit this enzyme. Why? Because you want higher levels of acetylcholine, okay? In Alzheimer, you want higher level of acetylcholine. And you can get it by giving these three medications, okay? Now, which of these medications can cause sleep disturbances? Like donepezil, okay, it can cause sleep disturbances. It can cause insomnia in some patients, okay? So the answer here would be C. The answer here is C. Donepezil is acetylcholine inhibitor that leads to increased acetylcholine. It is used in Alzheimer's for all stages, okay? All stages, not just late stages. And it includes, the side effects include bradycardia, insomnia, and dizziness, okay? Very important. Now, let's move on to the next question. So remember, donepezil, rivastigmine, galantamine, acetylcholinesterase inhibitor is the method of action used in all stages, okay? And these are the side effects, some important side effects. Next question. Which of the following drugs decreases glutamate release in Alzheimer's disease? Remember, in these pharmacology lectures, it's very important to remember the methods of actions of different drugs, especially when you have one drug that has a weird, different method of action. They're definitely going to ask about that drug because that's a unique thing. You know, they like to ask about unique things. So here, which of these drugs would decrease glutamate release? The answer would be, can it be A, B, or C? And can it be A or B? No. Why? Because I literally just explained to you the methods of actions of A and B. Can it be C? No. I'll also explain to you later why what's benztropine is. And can it be E? Aducanumab. That is a monoclonal antibody. Okay, it's an antibody. So that's this method of action, monoclonal antibody. So it's not going to lead to decreased glutamate release. The answer is D. Memantine is an NDA receptor antagonist. It blocks it and blocks calcium ion entry. This leads to decreased glutamate release, which is associated with decreased neurotoxicity. So we can also conclude that memantine decreased. Okay, so yeah. So I can ask you three different questions from these two lines. One, what receptor does it block? NMDA. Two, does it block calcium channel entry? Three, glutamate release. And four, it is associated with decreased neurotoxicity. Four different questions from these two lines. So you want to remember all this. It decreases neurotoxicity as well, okay? And it can be used in later stages of Alzheimer's disease, okay? So these are two classes of very important drugs used in Alzheimer. Acetylcholinesterase inhibitors and memantine, which is an NMDA receptor antagonist. And then aducanumab, which is a newer drug in the past 2 years. It's a monoclonal antibody, okay? So let's move on to the Parkinson question. So Let's see what's happening in this patient. He has Parkinson, and he's been on levodopa carbidopa, which is the most common uh, medication that's used for Parkinson. Okay, and then since being diagnosed for 5 years ago, he has required increased medications. So the medication is not being as effective anymore. He's getting worse. So now he's getting worse. His motor symptoms are fluctuating. What can you do next? You can give another drug, right? Now, what drug can you give? So you know how you start off with levodopa, carbidopa in these aged patients with motor symptoms like these, okay? Now, what's the next step? Entacapone is added, okay? Remember that. Now, what is entacapone? That is the answer to this question. So can it be A, decreasing peripheral levodopa degradation? That is the answer. It is the answer A. Now, why is it not B, C, or D? Okay, C. So let's look at this. B, directly stimulating dopamine and receptors. That's wrong. That's direct. It's its own class, which include drugs such as pramipexole, ropinirole, and apomorphine. So these are direct dopamine agonists, a different class. Okay. Now, why did I bold apomorphine? Remember how I said they like asking about unique things? Okay. So apomorphine is the only drug here that can be injected. The rest are oral formation. So apomorphine can be injected. So they might give you a patient that's getting an injectable drug. What is the drug? You will remember that that's apomorphine. And just because it ends with morphine, it is not used as a painkiller. It is not a common morphine that's used as a painkiller. Okay, it's used in Parkinson as a direct dopamine agonist. Now, what's D? Inhibiting central muscarinic receptors. That's benztropine, which you will see now in a bit. I'll give you a question about that as well. Very important. E, inhibiting centrally active. What is this? Inhibiting centrally active acetylcholinesterase. I literally just explained it to you before this. That was the donepezil galantamine, rivastigmine. Is that used in Parkinson? No, it's used in Alzheimer. So E is for Alzheimer, okay? So let's move on. So this COMT inhibitor, the answer was A. So entacapone, how it works is levodopa can either be degraded by decarboxylase into dopamine, but you're already giving carbidopa, so you're inhibiting that. As a result, instead of decarboxylase inhibiting levodopa, you're going to have a different enzyme. Because why? Because carbidopa is blocking this. The different enzyme is COMT. COMT is going to break down levodopa into 3-O-methyl-dopa, which will compete with levodopa. So you don't like that. You don't want that. You don't want 3-O-methyl-dopa. So what can you do? You can give COMT inhibitors like entacapone. Okay, that is the answer for this question. Now, a very, very important thing I want to elaborate on is the role of acetylcholine in Parkinson versus Alzheimer. This is very important to you. It's extremely important because this is how they trick you. Because this is a place where there can be conflicts between two diseases that are similar and how they trick you. Okay, remember how we said in this question, acetylcholinesterase in Alzheimer, you like to give, you want more acetylcholine, right? In Alzheimer. Here, let's focus on Alzheimer first. It's associated with acetylcholine deficiency. So you want to give something that will increase acetylcholine, okay? So how can you give that? You treat it with these medications. What's so important here is to remember that you want more acetylcholine in Alzheimer's disease, okay? And you do that by giving acetylcholinesterase inhibitors. You give the enzyme, you block it. Very important. Why is that important? Because it's the opposite. It's the opposite case in Parkinson. In Parkinson, because you have less dopamine, as a result, there's going to be a higher level of acetylcholine. It's a balance. The balance is going to be shifted towards higher acetylcholine, opposite to Alzheimer. And that acetylcholine that's so high, it can cause the motor symptoms such as tremor. So to combat this, what do? You antagonize the acetylcholine receptors, the muscarinic receptors. You block acetylcholine from working. This is complete opposite to Alzheimer's, okay? And you give so how do you do that? You give benztropine. Benztropine, it blocks the muscarinic receptors. Why is it so important? Look, in this question, which is from UWorld, they literally put it there to confuse you. That's how important it is. They're putting it there to confuse you. So what was the summary of what I said? Parkinson has high acetylcholine. you want to decrease it by giving an antagonist, benztropine. Alzheimer has low acetylcholine. You want to increase it by giving the enzyme, you inhibit the enzyme that breaks down the acetylcholine, so acetylcholine can stay there for longer, okay? I hope that explains it. Just pause on this and make sure you understand it very well. If it doesn't come in the exam, wallah, it's going to come in the future in your boards and steps, etc. Sorry, okay. Now, let's see this question. So, vivid dreams and nightmares, this is just a fact that you want to remember. It's in the lecture. Levodopa can cause this, okay? Levodopa, the answer is D, okay? So that's it for the degenerative diseases. What did we talk about? We talked about Parkinson and Alzheimer. Okay, Alzheimer, remember the two classes. You have memantine, okay, and then you have the acetylcholinesterase inhibitors, and then you have the newer drug aducanumab. And then for Parkinson, remember you have levodopa, carbidopa, okay? Carbidopa inhibits decarboxylase, while entacapone inhibits COMT, okay? Two different enzymes inhibited by two different medications. And then you also have the direct dopamine receptor agonists, okay? Which include pramipexole, apomorphine, okay? Yeah, and then remember, acetylcholinesterase, you block it, okay? Benztropine. Benztropine, very important. It's good for the motor symptoms like tremor, okay? So benztropine is good for tremor, okay? Now let's move on to antipsychotics. So antipsychotics used in things like schizophrenia or something, okay? Okay, so this is a question of a guy who's wandering in the streets barefoot and shouting to himself. So this is like paranoia. You can also see he takes antipsychotic medication. So they're all already telling you that this patient has something antipsychotic, okay? But it's not working, it seems. And look at this sentence. It's extremely important. Previous trials of haloperidol, quetiapine, and risperidone resulted in minimal improvement. Okay, so he's already been on 3 drugs before, it hasn't helped. And on mental status examination, the patient is alert and restless with poor grooming, disheveled clothing, and flat affect. See, poor grooming, disheveled clothing, these are negative symptoms of schizophrenia, okay? He refuses to answer most questions, accuses his parents of being part of the conspiracy. So he feels like he's either has delusions or hallucinations, which are positive symptoms, okay? So I'm trying to explain to you the pathophysiology as well as the pharmacology. Now, which of the following medications? What did you choose? I hope you chose D. Why D? Okay, the answer D. Why? Because specifically because of this. Previous trials of haloperidol, quetiapine, and risperidone resulted in minimal improvement. That is extremely important, okay? Because what they're trying to say is that he has resistant schizophrenia. Haloperidol, remember, it's a first generation antipsychotic. Quetiapine and risperidone are second generation antipsychotics. So in resistant schizophrenia, you give the drug clozapine. Clozapine is a dangerous drug because it has some severe side effects, okay, which we'll see right now. So remember, the what you want to get from this question is that resistant schizophrenia you treat with clozapine, okay? So yeah, like I said, now important side effects of clozapine. So it includes metabolic syndrome, what is metabolic syndrome? Which is common for all second generation antipsychotics. It's when you gain weight, when you get diabetes, when you get hyperlipidemia. This is common in second generation antipsychotics like clozapine, quetiapine, olanzapine, okay, risperidone. Agranulocytosis, this is very important. Agranulocytosis, decreased white blood cell count. A decreased white blood cell count can predispose you to infections. So how can they ask you a question about clozapine side effects of agranulocytosis? By telling you that a patient comes with infections, and then you do look at his labs, extremely low WBC count. That could be because of clozapine, okay? So that's why you want to monitor clozapine. You want to monitor its WBC counts when a patient is on clozapine. Everything I just said right now is extremely important. Don't think only the answer is important. Everything is important. Clozapine. resistant schizophrenia. Used, it's a second generation antipsychotic. It causes metabolic syndrome, agranulocytosis, seizures. Because it causes agranulocytosis, you want to monitor the WBC counts. And because agranulocytosis can lead to infections, okay? That's how they may present. Next question. Okay, I don't know why I'm waiting. So, okay. So this is a patient. He has schizophrenia. They're telling you. He was started with haloperidol a few days ago, okay? But then he got an acute muscle spasm in his neck. What can this acute muscle spasm be? Extrapyramidal side effect. Acute dystonia. Okay, it's when you get a sudden muscle spasm. It can happen in your eyes. Your eyes will suddenly look up because the muscles are spazzed, causing your eyes to look up. If it happens in your neck, you faj'a, you look like that, and you just have a spasm. You can't look at the other place, or like that, or you look back, okay, and it just stays there because your muscles are spazzing. That's acute dystonia. And from the name acute, it is acute. It happens within hours to days, okay, within a few hours. 2 hours, you can get the side effect. More common in first generation antipsychotics like haloperidol. That's why they gave him haloperidol. I mean, that's okay. Now, another extremely important thing from this, okay, is that the patient was treated with benztropine. Why is that so important? Because extrapyramidal side effects like akathisia, acute dystonia, okay, uh, tardive dyskinesia, some of them can be treated with benztropine. Okay, now let's pause for a second and connect two different ideas together. Right now we're doing antipsychotics. Let's remember what I taught you in Parkinson. What did I say in Parkinson? There was high acetylcholine. What did the acetylcholine lead to? Motor dysfunctions like tremor, okay? Here, what's happening in schizophrenia? Haloperidol. What does haloperidol do? It inhibits dopamine. So when you inhibit dopamine, it's the same thing as Parkinson. Parkinson has low dopamine. Same as haloperidol. It's going to lead to low dopamine. What happens to the balance of dopamine and acetylcholine? Low dopamine is going to lead to high acetylcholine. So you're going to get the same thing here. See how you can connect two different ideas when you understand the concept behind it, okay? And what did I tell you how we can treat the Parkinson high acetylcholine? By giving benztropine. Very important. So now what did the question ask? Okay, see, معلش, يعني, I'm not even answering the question because this is why doing questions like these are very important, because they teach you several different concepts in one question. I can teach you 6 concepts in one question, okay? And these 6 concepts can be asked in different ways, in 6 different questions. So one question is giving you 6 questions. Okay, this is why doing questions are extremely important. Okay, now he was changed to quetiapine. Okay, because of its lower risk of similar dystonic side effects. In addition to dopamine D2 receptor antagonism, what other pharmacological effects does it have? What is quetiapine? Quetiapine is a second generation antipsychotic. How do second generation antipsychotics work? By inhibiting dopamine receptors, as well as the answer here is the serotonin receptor antagonism. So that's the unique thing about second generation antipsychotics, which does not happen in first generation antipsychotics. Okay, the answer is D. Okay, so what did we learn from here? Extrapyramidal side effects, what they are, more in first generation, treat with benztropine, and the method of action of quetiapine. Great. Next, so this is extrapyramidal side effects, very important to remember. Acute dystonic reaction, sudden onset, sustained muscle contractions. Akathisia, which is subacute, subjective restlessness with inability to sit still. Very typical. The question will tell you the patient just moving around in the room. He can't stay in one place. Okay. And then drug-induced Parkinsonism from the name. And then tardive dyskinesia is long-term. Okay, lip smacking, chorioathetoid. This most commonly happens with first-generation antipsychotics. Okay. Now listen, I just want to tell you, okay, I've done USMLE step 1 and step 2, and these are all very high yield information that I'm giving to you, okay? These are all questions that are extremely high yield. Okay. Now another patient was given aripiprazole. What is the method of action of that? Okay. Aripiprazole, why did I choose aripiprazole? Remember I told you some medications have unique effects? This is one of those medications. Aripiprazole causes D2 partial agonism. The others are antagonists. No, this causes partial agonism. Okay, very important. The answer here would be C. And as you can see, the aripiprazol's method of action is different from those of other typical atypical antipsychotic drugs. It is a partial agonist at the D2 receptors as well as 5 serotonin receptors. 5-HT is serotonin. Okay, that's why the answer is C. Great. Okay, now we can move on to the next question. A patient is given quetiapine. What is quetiapine? It's a second generation antipsychotic. What are second generation antipsychotic method of action? D2 receptor antagonism and serotonin receptor. Okay, remember that. And now, which of the following should be monitored? Why should something be monitored? Maybe because of its side effects. What can side effects of quetiapine include? Second generation antipsychotic. I told you its side effects include metabolic syndrome. Metabolic syndrome, where you become fat, you become you overweight, sorry, and then you can get diabetes and hypertension and dyslipidemia, hyperlipidemia. Okay, so you want to monitor that. How can you monitor it? By doing glucose levels and lipid panels. Okay. Now, what are the other options? A, thyroid function tests. Why did I put it there? Because that's used for lithium. Lithium is used in bipolar disorder. It's another lecture. That's for lithium. B is the answer. C, white blood cell count. What does that remind you of? It reminds you of, I hope you're telling me clozapine. Clozapine you monitor. Now, D, you don't do that. You don't really monitor the levels of the drug specifically. Okay? So, answer B, yes, sir. So these are the common antipsychotic effects. Remember, chlorpromazine is a first generation antipsychotic. It's low potency. Okay. It has some anticholinergic side effects, which can lead to sedation. Orthostatic hypotension is from blocking alpha 1 receptors. Okay. So that's why we don't like it, because it blocks many other receptors like muscarinic receptors and alpha receptors, chlorpromazine. Okay. So yeah. Oh yeah, sorry. Okay, now we're talking about antidepressants. So let's take a step back of what is the important things in antipsychotics. First generation versus second generation. First generation, haloperidol, chlorpromazine, fluphenazine, okay? They have severe extrapyramidal side effects. Chlorpromazine also blocks muscarinic receptors, causing anticholinergic side effects like dry eyes, dry mouth, you're thirstier, blurry vision, sedation, sleepiness, okay? And then second generation side effects, aripiprazole, D2 partial agonist, quetiapine, olanzapine, clozapine used for resistant schizophrenia. Okay, very important. Remember these. So I feel like I'm giving you a session, pharmacology session, and also trying to review everything as well, okay? Because it's very important to review as well. Now let's go on to antidepressants. So antidepressants, we have classes of antidepressants. The most common, serotonin receptor inhibitors, reuptake inhibitors, the transporter, SSRI, that is SSRI. You also have SNRI, which is serotonin and norepinephrine receptor uptake inhibitors, reuptake inhibitors, sorry, okay? And then you have atypical antidepressants like bupropion, mirtazapine, trazodone. These are all atypical, okay? Because they have weird methods of actions as well. And then you have others that are less commonly used today, like the tricyclic antidepressants and the MAO inhibitors. These are less commonly used today, unless specific indications are given. So what is the answer here? Now, why do I like this question? It's very long, right? But because you are also understanding what major depressive disorder is. This patient is coming to you for past several weeks. Okay, how do you diagnose major depressive disorder? Remember, it needs to be for more than 2 weeks, the duration of the symptoms. The symptoms, CG caps, okay, suicidality, insomnia, guilt, energy, weight gain or weight loss, okay, psychomotor retardation, sleep, okay. The patient has all of them. I've been feeling down. I don't feel like doing anything. He's losing his motivation in life. Okay. My appetite is poor. Another thing. I no longer go out with my friends. You stop doing the things you liked. Okay. And then he says, I wish I could go to sleep and not wake up. Suicidal ideas. He has difficulty getting out of bed, sleep disturbances. See, this is why doing questions is good. Now you're going to remember the symptoms of major depressive disorder from this question, okay? Now, a patient with depression comes to you, how do you treat him? Like I told you, SSRI is the main idea, the first line first line treatment, which is C, not B, not B, C. Okay, that's how it works by inhibiting the reuptake. Okay. First line for unipolar depression. What is unipolar depression? AKA major depressive disorder. It is different from what? It is different from bipolar disorder, which also has manic episodes. You do not want to treat those patients with these antidepressants because it can induce manic phases. So what are some SSRIs? Sertraline, citalopram, and remember, it takes a few weeks to kick in. It doesn't happen على طول. So that's why if a patient comes to you after a week of taking SSRIs and like, hey, this doesn't work, you tell them, relax, take it for a bit longer, and inshallah, it will kick in. Major side effect, sexual dysfunction. That's very important because it's a unique side effect to these medications, okay, of SSRIs. So erectile dysfunction, anorgasmia, stuff like that, okay? And very important also to remember, bupropion does not cause sexual dysfunction. So that's why people like taking bupropion, because it does not cause sexual dysfunction. Bupropion is an atypical antidepressant. Remember that. It is not an SSRI. So what did we learn from this question? How to diagnose depression and the most common medication. So yes, sir. So this is it. Okay. Patient. He's depressed, given medication. He comes back with dry mouth and blurry vision. He feels very sleepy. What do these make you think of? Dry mouth, blurry vision. What did I tell you? Anticholinergic side effects. Okay, feels very sleepy. So which of the medications was likely administered? Which of the following? Okay, if you don't know the specific drug, what is the class? Because I literally just mentioned the class of drugs. It is the tricyclic antidepressants. What is A? Sertraline. Sertraline is an SSRI. It does not cause anticholinergic side effects. B. Duloxetine is an SNRI. Serotonin norepinephrine reuptake inhibitor. Does not cause anticholinergic. And then D is citalopram, is SSRI. You're left with C. Amitriptyline. Amitriptyline is a TCA. This is from your lecture. So amitriptyline, look at this nasty nasty method of action here. Competitive antagonists of everything on earth. It blocks acetylcholine, it blocks histamine, it blocks serotonin. We only benefit from this serotonin. So from these other, you can call it HAM. That is the mnemonic for remembering the side effects of tricyclic antidepressants. HAM, HAM, histamine, adrenergic, and then muscarinic. And then each of them are going to have their own side effects. Histamine receptor, you block them, you're going to get sleepiness, okay? Adrenergic receptor, you're going to block them, you're going to get orthostatic hypotension. That's when you stand and you just feel dizzy. And because why? Because you're hypotensive when you stand, okay? And then muscarinic, which causes blurry vision, dry mouth, it causes constipation. It can affect your ability to urinate as well, okay? So a patient's going to have difficulty with urinating. Examples of that include amitriptyline, imipramine, okay, chlorimipramine. They all end with in, okay. Now, so yeah, like I mentioned, dry mouth, blurred vision, constipation, postural hypotension, can't pee, can't see, can't spit, okay, can't shit. Okay, next question. Does this patient have schizophrenia or unipolar depression or major or bipolar disorder? What do you think? Good question. Now, let's look at this. He has been acting crazy for the last 2 weeks. He has hardly slept. No sleep. That's a sign of bipolar. He's worked on miscellaneous projects, multiple projects, working on multiple projects, spent thousands of dollars. Okay, grandiose. That's just throwing money. That's a very common thing that you can see in bipolar. And his speech is rapid. Okay, these are all, and he feels spectacular. Grandiosity. So these are literally, each of them are telling you symptoms and signs of bipolar disorder, okay? So which of the following medications is the most appropriate agent? So why is it, what do you think the answer is? I hope you're telling me the answer is F, valproate. Valproate is an anti-epileptic. How is it used for bipolar? Good question, and we'll see in a bit. But first, why is it not A, bupropion? Bupropion is used for antidepressant, only major depressive. Do not use it in bipolar. Same thing. What is C? First generation antipsychotic. We don't want to use it. D, lorazepam. It's a benzodiazepine. We don't want to use it because it's acute. Okay. Paroxetine. It's a SSRI or SNRI, one of them. But same thing. You don't want to use it. Okay. You're left with valproate. The answer. Okay. Treatment for bipolar disorder, you might have thought about lithium. It's not just lithium. It also includes valproate, lamotrigine, carbamazepine, okay? So now lithium is the most common drug used, and remember, its side effects include a few side effects. It can cause thyroid dysfunction, so it can cause hyper or hypothyroidism. It can affect the kidneys, okay? It can cause nephrogenic diabetes insipidus. If you've taken the kidney module, you should know that. That's lithium, okay? Now, you can also use anti-epileptics in bipolar disorder. Look at valproate, lamotrigine, carbamazepine. You have 3 different anti-epileptics that can be used for long-term treatment in bipolar disorder. And you can especially use them when the patient also has epilepsy, okay? Because it's going to be 2 in 1. And let me ask you this. What are the methods of action of valproate and carbamazepine? Carbamazepine, if you remember, it blocks sodium channels. Valproate blocks sodium channels as well as what? It inhibits the GABA transaminase enzyme. Remember? Okay, good. I hope you remember. So yeah, so that was for bipolar disorder. Okay, now next question. He has depression, but he also complains of not gaining weight. So you have 2 different complaints, okay? Now you want to give him a medication that will also cause him gain weight. You want to give him a medication that has a side effect of weight gain. Which one of the following 3 are is that medication? The answer is B. Mirtazapine can cause weight gain, okay? Increase in your kilograms. And this guy's BMI is 17, which is very low. So it's going to help him. Bupropion can actually cause weight loss. Bupropion is not good for him. Bupropion can cause weight loss. Trazodone. Okay, so these are the atypical antidepressants. Bupropion, it inhibits dopamine as well. The reuptake of dopamine. Okay, sorry, reuptake of dopamine. So it will lead to more dopamine. So that's why it's atypical. It has different method of action. This is, I think, the only one that benefits dopamine as well. Bupropion. Okay. Trazodone, serotonin antagonist and reuptake inhibitor. So both of them. Yeah. Mirtazapine, noradrenergic and specific serotonergic antidepressants. So this is the one I just told you. Weight gain. Look at that. Yay. So now we move on to stimulants and drugs of abuse. Okay. So let me just take 10 seconds to drink water. Okay. What did we just learn in the antidepressants section? We have SSRIs. They're the first line in treatment. They include sertraline, citalopram, okay, 2 of the most common ones. You have SNRIs, second most common used. You have MAO inhibitors like selegiline, okay, not used as much anymore. And then you have also the TCA, tricyclic antidepressants, like what? Amitriptyline, imipramine, and they cause HAM, antihistamine, antiadrenergic, anti-acetylcholine side effects. Okay, and then we saw that in bipolar depression we can use lithium, we can use valproate, carbamazepine, and we can use lamotrigine. Okay, so that's just, and also in bipolar disorder you can also use antipsychotics like quetiapine, but those are usually for acute short term, I think. Okay, so yeah. So now let's move on to the next part. Does anyone have any questions? I was just, okay, just kidding. Okay. Okay. So this patient has, no, wait, how come this is a question on stimulant abuse, but it talks about depression, right? No, I'm not, I didn't put it in the wrong area. Don't worry. So he has depression, but he also has an addiction to smoking. He smokes 2 packs of cigarettes a day. So which one of the following medications is the best option for this patient? So if you remember, these are all. So the best answer is D, bupropion. Why? Because this is the lecture of stimulants and abuse, nicotine. Okay, the nicotine addiction. You can use nicotine replacement therapy. Varenicline is also a drug. It's a nicotine receptor partial agonist. You need to remember partial agonist. Don't just think, oh, complete agonist, antagonist, okay, or agonist. Partial agonist, varenicline. It's a common question. Don't think this is a random drug. No, it's a common drug. And then bupropion, it's also helpful in smokers. Okay, so when you have a guy that smokes and he's depressed, bupropion is an amazing option for him. Okay, that's why I wanted to connect the two topics together into one. Okay, so that's the answer. So remember, so let me ask you this: for a guy that has nicotine addiction, what are some medications you can give? I hope you're telling me bupropion, and the next one is varenicline. What is the method of action of varenicline? What is the method of action of varenicline? It is a nicotine receptor partial agonist. Why? Just think about it. Let me explain to you why do you wanna agonize it partially? If you I Because it's gonna give you some effects of nicotine that the patient might want. Okay, he stays there, so you don't get withdrawals at all. You don't want to get withdrawals at all, so that's why you want to give some agonism partially. Okay. Yep. Now let's move on to the next question. So, patient, 23-year-old, he's paranoid and he has conjunctival injection. What is conjunctival injection? It is when this conjunctiva becomes red. It's completely red, okay? And the dry mouth, for which he keeps asking water for. So, which of the following drugs may be a cause for his presentation? Very easy. The answer should be C. Okay, marijuana causes dry mouth and red eyes. It's something known. Probably you see in TV shows or something. Okay, so the answer is C. Marijuana, when you're long-term use, can also cause like a stony effect. You just become like the word called stoned. Just you just always relaxed. Nothing like that. Yeah. So why is not A? Because none of the other medications cause conjunctival injection, dry mouth, and you will see what the other medications cause. Heroin is an opioid. Opioid intoxication leads to meiosis, where it shrinks, your pupils shrink. Respiratory depression as well. Okay. Nicotine, there's not a common acute intoxication of nicotine. LSD is a hallucinogenic. It causes hallucinations. Okay. So this is marijuana. It's also aka cannabinoids, so you can get both words. Increased appetite, you become very hungry. Euphoria, conjunctival injection, and dry mouth. Okay, remember that. Slow reflexes. Now let's move on to the next question. So what does the patient have? So he says he assaulted someone, so he's aggressive. He's aggressive. Okay, I don't know if you can see the question with my camera outside. Okay, so he's aggressive after he assaulted a stranger who he thought was following him, assaulting. Okay, so he's aggressive, and then he says, "You don't understand. I'm the one who needs protection. The Russians are after my secrets." He's either having hallucinations or delusions. Okay, one of those two. He's diaphoretic. What does diaphoretic means? It means he's sweating. Okay, easily distracted. And then look at his blood pressure. It's extremely high, 164 over 2, 1 over 2. So he's hypertensive. And hypertension in a 31-year-old, is that common? Not really. And then also he's tachycardic. And now very extremely important, his pupils are dilated. So what does this all connect to? It connects to the answer being B, cocaine intoxication. Cocaine is a stimulant. So that's why it's stimulating everything in this guy, making him aggressive, making him tachycardic, hypertensive. The cooking questions are always very easy, okay? Pupils dilation, remember that. Mydriasis, okay? Remember, mydriasis, pupils are dilated. It's a longer word, so remember that, okay? Cannabis intoxication, I literally just explained to you. dry mouth, conjunctival injection, schizophrenia. Why could this not be schizophrenia? For two reasons. Number one, schizophrenia is not going to have hypertension and tachycardia. And number two, it would be long term, more than 6 months. Remember, schizophrenia has symptoms longer than 6 months. Schizophreniform disorder between 1 and 6 months. Schizoaffective less than 1 month. I think you want to double check that because this is kind of a formal lecture. Yes. Okay. So that's for stimulants and abuse. Okay. That's I'm just trying to get the most commonly asked, because of time's sake, I don't want to just go over everything. I want to make sure you do the most high yield questions. Okay. And so yeah, so cocaine, remember, leads to stimulation, etc. Now, cocaine, when it's used through the nose, it can cause necrosis of the nose. So you might get a picture where the nose is damaged. The patient's nose is just damaged. It's necrosis. It's extremely shrunken. That can be from cocaine as well. Remember that, okay? Uh, we talked about cannabis, nicotine. Nicotine's okay. Yeah. So let's move on to meningitis. Meningitis, it's kind of easy, okay? Meningitis, you want to know a few things. You know how they're just like these common things you can find in different lectures, okay? Meningitis, number one, you want to know the age of the patient. The age is extremely important, very important, okay? Why? Because in certain age groups, you have different bacteria that cause meningitis in that age group. As a result, that you know that there are different bacteria causing the infection, you're gonna give antibiotics that target those bacteria, okay? So three things. What age group? Which bacteria, and then which antibiotics, which is the treatment. And then you're also going to have, okay, great, great. So this is the first question. 72-year-old man. 72-year-old, neck stiff, severe headache since a few days, acute onset, high fever, typical signs of meningitis, okay? Which of the following medication should you be given? First of all, let's look at his age. 72-year-old. 72-year-old, he is part of the bracket of above age 50. Anything above age 50 is going to have the same antibiotics that we're going to give him. What antibiotics are we going to give him? The answer is C. Ceftriaxone, vancomycin, and amoxicillin. Okay? Why? Above 30, so you must ampicillin to cover listeria. Above 50, they're also they're kind of considered immunocompromised because the older you get. So in the immunocompromised, you can get listeria. Listeria monocytogenes can come from dairy products, okay? It's a bacteria. And then so you give ampicillin, which is a penicillin for listeria to cover that, and then you give ceftriaxone and vancomycin to cover strep pneumo and Neisseria, because strep pneumo and Neisseria are also very common in this age group. And don't forget the method of action of vancomycin, which it inhibits bacterial cell wall synthesis by inhibiting peptidoglycan polymerization. Okay, this table is super important. I cannot tell you how important it is, but let me try to simplify it for you. Okay, it looks like it's a lot of words. I know, don't worry. First, you have the first age group you have is less than 3 months. Anything less than 3 months, okay. Less than 3 months, you have Streptococcus agalactiae, very important. You can also have strep pneumo, Neisseria, and Listeria. I'm gonna be honest with you, okay? Now this is just me, my experience. You want to keep this or not, up to you. This Enterobacterium adriesh rarely comes in exams. So just remember, strep agalactiae, strep pneumo, Neisseria, Listeria. Strep pneumo, Neisseria is in every age group. Strep pneumo, Neisseria, every age group. Every age group, okay? And then specifically, you have strep agalactiae. Strep agalactiae only less than 3 months. Only strep agalactiae. Listeria monocytogenes, okay, it's gonna come in three different categories. Less than 3 months, above 50 years, and immunocompromised. Remember how I told you less than above 50 years, they kind of have immunocompromised. So it's gonna be easy for you to remember that above 50 years and immunocompromised patients are gonna have the same treatments. Now, Amr, what's the difference between above 50 years and immunocompromised? They're not the same thing. Immunocompromised, someone can be 25-year-old, have a kidney transplant or liver transplant or bone marrow transplant, and he's taking immunosuppressive medications. Okay, so now, now look at okay. So just follow me, okay? Follow what I'm saying. I started with the age groups, the common pathogens, and now uh, the antibacteria. This is a lot of things, okay? Just remember, in neonates and infants above 50 years and immunocompromised, they all have the same treatment. Vancomycin, ampicillin, and then a third generation cephalosporin. In this patient here, we give him ceftriaxone, okay? Less than 3 months, we can give him a different cephalosporin. I don't want to get into details of that, okay? So, um, yeah. And now, so that's the first age group. The second age group is 3 months to 18 years, where they have, like I said, strep pneumo and Neisseria, but they also have Haemophilus, but the same treatment. Ceftriaxone, vancomycin only. Ceftriaxone, vancomycin is so high yield. But for your sake, remember third generation cephalosporin and vancomycin, okay? And then 18 to 50. And I give you a trick here. From 3 months to 50 years, same treatment. From 3 months to 50 years, same treatment. Ceftriaxone, vancomycin, or a third generation cephalosporin and vancomycin. Okay, so let's recap meningitis. Let's recap meningitis. First, what are this is how you need to study. You need to stop and you need to ask yourself, what is this? What is this? What is this? Okay. So what are the bacteria that cause infections in the different age groups? We said Listeria monocytogenes can cause infection in less than 3 months, in above 50 and immunocompromised. Strep agalacti, it's only in less than 3 months. Streptococcus pneumonia and Neisseria meningitis, all age groups, okay? And then Haemophilus influenza, 3 months to 18 years, okay? So that's for meningitis, okay? So that's it for my lecture. Okay, I hope I covered a lot. So I'm gonna include more questions in this lecture. You're gonna see more questions. Um, so I think you guys, I'm assuming you guys get the slides. Now, if you guys do get the slides, there's gonna be more questions for you to answer yourself, and then you're gonna have the explanations as well. Okay. Now let's try to summarize everything we learned today. Anti-epileptics, methods of actions, side effects, different uses. Antidepressants, same thing, okay? Different groups, their different mechanisms of action, the different side effects they have. SSRIs cause sexual dysfunction. TCA can cause uh, anticholinergic side effects. HAM, remember? MAO inhibitors can cause hypertension if it's combined with tyramine, like cheese, okay? Mirtazapine, weight gain. Bupropion, weight loss. Bupropion also used in smokers, okay? Antipsychotics, first generation, causes extrapyramidal side effects, okay? Uh, and it causes acute dystonia, akathisia, tardive dyskinesia, Parkinsonism. You can treat some of those with benztropine, okay? So just remember all of these things, and inshallah, in the next few questions I'll give you, you can answer, you can try to solidify all the information I taught you. Now, you guys, my biggest advice for you as a fifth-year medical student that's finished his steps, my biggest advice for you is to do questions, as many questions as you can. Questions on top of questions, okay? Many questions. I highly recommend you to use Amboss. Do their questions. I highly recommend you to subscribe to them. I know it's not free anymore. It still costs some money, but it's a very good investment. It's an investment that's amazing, okay? That's Amboss, okay? Because like I told you, like I just showed you guys right now, one question in Amboss, in these books can give you 6 different concepts and solidify it in your brain, okay? Taking notes and reading it over and over again, it's not as helpful. Anki is also helpful, but the top goat is the questions, okay? So you can do UWorld, you have the UWorld, you have UWorld files, okay? Amboss, there are different books like for pathology. I'm not talking about pharmacology only. I'm talking about every single thing. For pathology, there's like the rapid review questions, okay? You want to do as many questions as you can. You have 1 week break, Hagel Eid. I highly recommend you do questions in it. And inshallah, good luck in your exam. If anyone has any questions, yeah, if anyone has any questions, this is my phone number for WhatsApp, or my email, which would be better, is Ahmed, okay? Good luck. Ma salama. Assalamu alaikum.